At this year's meeting, in fact, I have discussed about risk factors for CAR T-cell therapy for patients with relapsed multiple myeloma. And what we know by now is that the dose of CAR T matters, in fact. And when you are looking at the KarMMa study with the ide-cel, if we are infusing an adequate number of CAR T cells, 450 million of CAR Ts, the response rate are totally different, and the progression-free survival is also better as compared with lower doses. We know that the expansion of CAR T matters as well, and we may be able to predict those patients with a long response when there is a true in vivo expansion of the CAR Ts. For example, with ide-cel, after 11 days, we have this peak of CAR Ts. And when the peak is really high, the duration of response is also longer. We know that some subgroups of patients are really benefiting less of CAR T-cell therapy. This is true for both CAR Ts that are already approved, ide-cel and cilta-cel. We know that patients with extramedullary disease have a lower response rates and also a shorter progression-free survival. This is also true for patients with a high tumor burden, ISS3, and also patients with high-risk cytogenetics seem to benefit less, in fact, of CAR T-cell therapy. We heard about an interesting presentation recently at ASCO and showing that we can put together different factors such as tumor burden, the prior therapy that the patients did receive before the CAR Ts, and we can integrate those different factors to try to evaluate the progression-free survival with 4 clusters, in fact. That's not yet published, but that's sort of indication of what we can do, in fact, to predict the outcome and maybe to select, in fact, the best treatment option, because we know that we have a restricted access to CAR Ts currently. In Europe, especially, we only have few slots for ide-cel, and in the majority of the countries, no access yet to cilta-cel. And on the opposite, we have now teclistamab, that is the first bispecific antibody targeting BCMA that is approved, and with quite a lot of compassionate use programs all over Europe. Maybe we can try to select bispecific antibodies or CAR T in the future. And that will be very, very important as well to understand what is the best sequence. And early data are showing that probably it is better to use, if available and if possible, CAR T first and one and done, and bispecific antibodies at the time of the relapse. If we are doing the opposite, if we are doing bispecific antibody first, then the CAR Ts are less effective, in fact, and this is true for cilta-cel, and a recent paper from Dr. Cohen showed that the response rate with cilta-cel after BCMA therapy, prior BCMA therapy, the response rate was decreased, in fact, from 95% to 60% only, and the PFS also was reduced as compared with the PFS achieved in the CARTITUDE-1 study for the whole patient population. So that's a very important question, the optimal sequence. And although the data are scarce and limited, in fact, we are thinking that it is better to use, if possible, CAR T first and bispecific at the time of progression of the disease.